Hello, good afternoon, everyone, and I welcome you all to our session today on the SARS-CoV-2 genomic surveillance lessons learned. This is the first of a series of talks we're planning to hold, and we welcome you all to the session today. Now, as we hope for the dreaded pandemic, the second wave of the pandemic to taper off, one can't really help wondering at the excruciating losses which have incurred globally, which has basically shaken all of us, whether it's of lives and livelihoods or for mental and social well-being. I think the pandemic has hit all of us really, really close home. But through all of this, one thing that has really stood its ground firm is the absolute indispensability of science, which has been the backbone of the entire framework of diagnostics, patient care and treatment, vaccine synthesis, and the topic of our today's discussion, disease surveillance via genomics. So I think in the history of our lives, for the first time, genomic sequencing and virus mutation conversations have really become dinner table topic of discussions. And we have people who have absolutely no inkling of what's going on, talking about the alpha, beta, delta mutants of the virus, and probably with good reason too. But I think beneath all of this, there are lots of questions which really need a bit of deep delving. Why is a sequencing-based surveillance required at all? And does it really affect the way the disease is managed? And also, I think more importantly, how do you kind of make it democratized? How do you actually reach it to the states, to the district level, patients and hospitals? So our today's speaker, Dr. Sridhar, who's an eminent scientist, and he's a senior scientist working with the Institute of Genomics and Integrative Biology, and who has worn multiple hats as a researcher, as a genomics researcher. He outlines some of his efforts in deconvoluting some of these questions. Now, Dr. Sridhar is absolutely very, very familiar with all of us who've been associated with genomics. His team was the first one to sequence the first person human genome from India, Sri Lanka, Malaysia, etc. And currently, his lab runs one of the biggest, centers for genetic disease, research. And he basically spearheaded the Genomics for Understanding Rare Diseases India Alliance Network, the Guardian network, which basically is a consortium, which spans across a lot of researchers and scientists who work in tandem with clinicians to deconvolute some of these rare diseases. He also has a very, very prolific fly lab, which is basically a zebrafish lab, where he's running a lot of genetic screens, which pulls out a lot of mutations having, developmental effects. And today, he's, like I said, he's basically going to be talking about his experts on his work for the INSACOG and his work with the states of Tamil Nadu, Kerala, and a lot of states across India. And he's going to be, outlining his observations and research findings for us. Without much ado, I call Dr. Sridhar to, give the talk. Thank you, sir.
Thank you, Dr. Debjani and the Premas team for the kind introduction and laying the groundwork for making sure I get to share the science that we do. It's not when I say I represent the Institute of Genomics and Integrative Biology in Delhi. It's a work done by a large set of team members, including students, volunteers, colleagues at IGIB. So a lot of people who have worked very hard through the pandemic, right from the day we had the first lockdown on 25th of March last year. We have been on the job. So I'm going to share some of the experiences that we have and what lessons have we learned. How could we do better in this using science to tackle this pandemic? But before I go ahead, just want a word of confirmation from somebody, Debjani, to make sure that my slides are visible properly.
Yes, Dr. Sridhar, you can see your slides.
Thank you. Yeah, so what I'm going to do in the next 30 to 40 minutes is to give you an overview about the genomic surveillance that we undertook in India and what lessons we have learned and what mistakes we have made and how could we improve upon them so that we could be better prepared than what we were last time. Okay, so let me start out. So it's pretty much now like Debjani introduced its dinner table conversation, but nevertheless to set the tone, let me put things in perspective. SARS-CoV-2 is an RNA-based virus. It has about 30,000 bases and is largely at the causative organism for the COVID-19 pandemic. It's well understood now. It had a potential outbreak from a seafood market in China, in Wuhan, and since then it has become turned into a global pandemic of proportions that none of us have ever witnessed before. Therefore, it has disrupted a lot of businesses, a lot of lives, and we hope we somehow be able to control this. That's the aim that we want. And one of the tools that we have for at our disposal, especially with the new variants coming up, has been genomics. Genomics has always been around in its traditional settings, which is in genetic diseases, in looking at whole genome sequencing of animals. It has been very much around. But I think this is one of the rare occasions where genomics meets virology in real time. Okay, when I say real time, it's happening. Almost you get to sequence genomes and you read about it next day, or you are part of that set of team where you see the new variants emerging, okay, on a real-time basis. So it's actually genomics meeting the virology in real time. Earlier it was used as a diagnostic tool. Now it's being used not only as a diagnostic tool but as a tool to track this virus down. Okay, so the way this whole thing works is that you take up the RNA virus, convert it into the cDNA, and then now sequence it. You can make smaller fragments of it. Once it becomes fragments, you can use one of the machines as shown on your left hand side to actually put together the sequencing, and then use high-end computational algorithms and computers to stitch them back together to make a whole genome sequence. So that's in a nutshell what we do. But again, the way this virus is sequenced is you could take saliva swabs or lavage, extract the RNA, and actually then sequence it out, do the base calling, and finally do the phylogenetic analysis. That's what actually happens behind the screen, as we say, when the genomes are sequenced. But before I go ahead with the genome sequencing topic, let me explain to you why we use genomics in the first place. Okay, so the virus evolves by mutations. Okay, this particular RNA virus, the SARS-CoV-2 virus, has a very modest substitution rates. It's much slower than a seasonal flu. Okay, so it's roughly estimated that it acquires one mutation every 7 days, or about 4 mutations a month. So if the blue dots on my screen, the large circles, denote an individual, as the virus goes from one individual to another, okay, as it transmits, every 7th day it acquires a small mutation or a change, and over time you accumulate a set of mutations, and one of these mutations provide the virus a selective advantage which leads to an outbreak, or you get into a settings where a large number of people gather together and one of these viral strains has a selective advantage in transmission or severity, then you have an outbreak. Okay, so it allows for molecular contact tracing. So the idea is to use this small genetic footprints that the virus leaves behind to track it, basically do this detective job of looking at this small variants and then figure out what happened. And sometimes if you are very lucky, you can catch it in the act. That's what is the final end point that we will get at, and show you how we can do it, and it is achievable today. Okay, so that's the premise on why we should do genome sequencing. So what does genome sequencing help us with? One, it helps us understand the evolution of the circulating virus. Compared to something like a traditional diagnosis such as an RT-PCR or one of its other ways of diagnosing this virus, you get to know presence or absence of the virus. But you really, if you need to understand what are its genetic composition, how does the virus change when it moves from one person to another, or even within the same person, okay, it helps us understand the evolution of the virus, and sequencing is probably the only tool right now out there that helps us do it. Okay, it provides, more importantly, confirmation of the virus. I'll show you data for this. Okay, many a times you doubt, do you have the infection, because all the diagnostic tests sort of stop at a particular threshold, and you're not really sure what really is causing the disease. And you can really use sequencing to confirm the presence of the virus. You can understand origin of the infection, you can look at the community outbreaks, you can also use it for developing newer diagnostics, vaccines, and therapeutics. So you can see how a simple tool like genome sequencing now becomes very powerful in multiple arenas. Okay, so now this slide is where most of you are very familiar with it. Okay, how COVID came to India. The first confirmed case was on January 30th, 2020, which was a student who traveled back from Wuhan, who accidentally brought it, but was contained, isolated, quarantined, and those days the quarantine was almost 28 days, and we are pretty good. But in the process, I think there are multiple entry points after this first case through various ports of entry, and by March of 2020, we started seeing some cases, and due to which the nation went into the first lockdown. By April 2020, we had over 20,000 confirmed cases, and we were dreading that this was a lifetime pandemic that we were witnessing, not really realizing that that was only the beginning of the pandemic. By April 2021, all of us know what we went through, and I need not really emphasize. Many of us, I doubt if there is anybody out there who has not lost an acquaintance, a near or a dear one, or some friend. So everybody, it has touched almost everybody on the planet. Okay, India has a confirmed case as of April 2021, about 230 lakh cases were there, and about 250,000 deaths were recorded. And since then the numbers have staggeringly increased only. They have not decreased. Only in the recent times we have seen some relief. But having said that, okay, I'm going to take you back almost 1 year, almost more than a year now. So when the first round of the pandemic hit us, we were all reeling, and everybody was busy establishing RT-PCR assays and doing RT-PCRs. A small set of people in CSIR got together, and we sort of came up with this notion that there is going to be a time point where this virus is going to evolve. There is going to be a time point where the virus will dominate this whole system so much that it's not, the individual tests are not going to be really very useful. You really need high throughput detection systems that can look at genetic epidemiology and at a scale and throughput required for India. And the scale and throughput is very important, because you could always sequence ones and twos, but really for a country like India, you really need scale. Okay, and at that point there's none available. So we toyed with a number of technologies, and believe me, it is more than about half a dozen of technologies we toyed around at CSIR. And by June, Illumina had gotten its emergency use authorization for the assay called as COVIDseq. Now, still this assay had gotten an authorization, but was not field tested. It was not clinically tested. It had not really been put through its rigors. So CSIR-IGIB partnered with Illumina to become globally the first lab to clinically and field test and validate this COVIDseq assay. And thereby we sort of knew that we had a high throughput detection system for SARS-CoV-2 that can also look at genetic epidemiology. And shown in the pictures are the great souls, my students and colleagues, who finally managed to get this whole act together of running this high throughput system. And it was largely a contribution from Rahul, whose picture is there, Abhinav, and his team, who put together this COVIDseq assay for the first time. And the way this works out is that you can take nasal swabs in VTM or any other medium, isolate RNA, and you prepare libraries, sequence them, analyze them on a high throughput platform such as the NovaSeq 6000 shown on the right hand side. Okay, this machine, the NovaSeq 6000, is a beast. Okay, it can do 3072 whole genome sequence of this virus in 48 hours. Okay, now that at that point when this was released, people were doing in ones and twos. Okay, so this was an unheard number. So it also required a lot of small innovations to make sure the assays worked. And we worked with Illumina and their partners to make sure this assay really got to working. And I'll show you our first experiences. I'll actually tell you 3 stories. I'll tell you the first experience of how we went through COVIDseq. I'll tell you about how it was used in a very accelerated manner in a very resource limited settings, and then I'll tell you how it was used for running a state level surveillance program. All 3 stories I hope to cover in this talk. So and this slide actually summarizes what we see for as a workflow for COVIDseq. It's a very complex workflow, okay, but those who start getting used to it kind of get this into a pattern. Okay, you could get patient samples, you can use a number of RNA isolation methods. It's very amenable to them. You could then prepare standard library and sample poolings that is done in an NGS experiment. You pool them, put them onto a flow cell into a NovaSeq machine, and then actually generate the sequences. And at this point, 2 things could happen. One, you could get a report by running it on a Dragon pipeline, or you could take the data out and run it on customized pipeline to get the results that you require. So to summarize, this particular platform, the COVIDseq, could sequence and you'd get the detection of the virus and understand the genetic epidemiology. It had a scalable configuration. That's very important because you could go anywhere from 300 to 3000 samples in a single go. That was very important. And here is the proof. So what we did is we took 752 samples, multiplied in duplicates to see reproducibility, and we ranged the 752 samples were of many varieties. They contained positives, negatives, inconclusive samples that had pan-Serboco classifications, various ranges of CT as shown on the right hand side, all the way from below 25 to above 30, and also inconclusive samples. We had included all of them in the first proof of concept run, and here is the data from it. So we generated about 705 GB of data with a pretty good Q30 score, with a sensitivity of 98.4% and an accuracy of 97.29% compared to a gold standard RT-PCR that we had already been doing in the labs. So compared to an RT-PCR, that was a sensitivity and accuracy, that was a basal data that we had to establish. Of course, the time was 12 hours, and from 752 unique genomes, we could pull out high quality whole genomes for 469 samples. All this data is now published. The publication where it's available, the data is freely available for people who would like to reanalyze it or understand it better. It's out there, so feel free to read it or contact Rahul Boyer, who is the first author. He would be happy to answer questions. But what did we do when we have an approach like this? This is exactly what we had predicted would happen as the pandemic breaks out across the country. Okay, there are small solutions that would look at positivity in the local settings, but could we have a country level surveillance going? Okay, that's where COVIDseq really became very useful. It was an ultra high throughput sequencing method with a very high sensitivity, and we could use that for driving genetic epidemiology. For example, in this particular case, what we did was this happened in August, September, October of last year, 2020, where we took 7 states to participate into this exercise. It included Tamil Nadu, Kerala, Maharashtra, Andhra Pradesh, Odisha, Uttar Pradesh, and Rajasthan. Of course, Delhi was also involved. About 2,000 genomes were sequenced, of which about 1,154 were of really high quality that we could really now make sense of into clades, into lineages. And in a nutshell, we identified 3 new clades, 2 lineages reported for the first time in India. And so we knew that the assay was working. and we could use it for potentially use it for public health benefit. Okay, so in a summary, what this COVIDseq did was to sequence the virus, use it for detection and also genetic epidemiology. It had a scalable configuration of 300 to 3000 samples in multiples of 300. It had better sensitivity compared to a conventional RT-PCR. It had a slightly better diagnostic yield, about 10% additional diagnostic yield compared to an RT-PCR. But the most important matter is that about 50% of the cases that are pan-Serboco. Pan-Serboco are those cases in which only the E gene, which is the envelope gene, turns positive, whereas your ORF1AB or your N gene turns negative. So you throw up a doubt, do we really have the family of viruses? Okay, we figured out that 50% of the cases that had a pan-Serboco positive are actually real COVID positive samples. That was because that added to the diagnostic yield in a large way. Of course, you could use this data for looking at population level epidemiology of the infection, and it also provides us the opportunity to become globally one of the first labs to validate this assay. And that was sort of the turning point, really, because nobody around the world had used these assays for running large-scale surveillance program, and here we had an opportunity to participate. What I'm going to do is I'm going to use what I showed you is how to use it at a very high, ultra high throughput manner. But on a practical note, okay, how do you use this? So here I'm going to switch gears and tell you a small story of how practically you could use the COVIDseq assay. Okay, so we call this the accelerated COVID-19 genome sequencing on a MySeq. Okay, remember this whole assay was developed on and fitted really to optimized to work on a NovaSeq. And but unfortunately, there are only a handful of NovaSeqs in a country, in India, and most countries don't even have one. So whereas MySeqs are present in a very ubiquitous manner, we have close to about, I believe, about 150 200 such platforms around in our country. I may be wrong, the numbers may be higher, but most countries have it. So we were very interested in looking at adopting COVIDseq for MySeq platforms, and we call this accelerated sequencing is because one, you could use it in a focused manner for a focused surveillance. Let's say a hospital outbreak infection, a community outbreak infection, a cluster infection that happens, or a cluster of deaths that happen. You need to figure out why is this death happening. It's in any time critical event where we are pressed for time, okay, and you need answers. I think this is the way, the MySeq is the way to go, and COVIDseq really works well because in about 24 hours, you can generate 48 sample reports. You can go from RNA to a full signed diagnostic report in 24 hours with a very modest cost of 5,000 rupees. Okay. Now, those who are interested in looking at this, the protocol works very similar to what I showed before. You can take RNA VTM samples, isolate RNA from a number of different methods. Okay, prepare the libraries, put them onto a MySeq and generate, and all this happens within 24 hours. And those who are interested more in the technical details, there is a manuscript which is currently under review, but it's also available in the in the preprint manner by Boyer et al. You are welcome to read that, and would be happy to handhold you if you have a MySeq and be interested in implementing it. I'm going to tell you how did we use this in a real-time basis. That's the next story. Many of you have heard this or read about this unfortunate incident in newspapers where there are close to about 34 deaths in 18 days, and most of them were professors at Aligarh Muslim University in Uttar Pradesh, and this was turning out to be a very nightmarish exercise for our colleagues at Aligarh. And the Vice Chancellor wrote an open letter to the head of ICMR asking for help. And this was the time when INSACOG had just put its foot down and was wanting to really be useful to the public. So the request came to us. INSACOG is a consortium of 10 labs around the country that looks at sequencing genomes so that we can understand what variants are out there. So the idea was, could we link this to a variant outbreak, or was there something else going on in this particular location? Now, we did not have a lot of time in hand. As you can see, the date stamp was 10th May. The publication, the open letter to ICMR and then various authorities went out on 10th May, and the request from the Vice Chancellor came on 10th May. 20 samples were received on the very date because it is only about 4 hours from Delhi. Libraries were prepared the next day in 7 hours. Sequencing happened in 12 hours 30 minutes, and analysis and reporting happened in 1 hour. In total, 21 hours. So in less than a day, you had the answer, and all the protocols that we have used are already published and available, extensively used by a number of international groups. So these are all nothing new. Okay, so in under a day, we had the sequencing done. We could get a very high sequence coverage of close to 1850 X coverage, with a mean genome coverage of 97.15. But most importantly, 18 of those 20 samples actually are assigned to B617.2, which is now called the Delta strain. Okay, and these were the very early days when people did not really know what was the effect of this strain and how will it really influence many of our lives. And we were sort of right there to confirm that about 18 of the 20 samples fell into this B 1.617.2, and one of them actually mapped to B117, which is the alpha strain, or the and one of them could be assigned to only the B1 because it had a slightly lower depth of genome coverage. Mean genome coverage was less. So clearly you can see within 24 hours you had an answer that could be communicated back to the people who asked those questions, and could also now take public health measures in a much more meaningful way, because you had science to go back to this community and tell them that no, there is a very dangerous virus, you need to take precautions. Okay, now people would listen to you better rather than saying just take precautions, because earlier it was thought that we had done with COVID and there will be no second wave, or people did not believe that there will be a second wave. And here science was saying that no, there is already a new variant that's out there. So that's the first story, where clearly you could use accelerated genome sequencing and go back and use it. And now we have used this accelerated genome sequencing, I think, over about a dozen times now for many other settings, like identifying reinfections, breakthrough reinfections, hospital-acquired infections, looking at small clusters, looking at pediatric cases in a small cluster. We have applied to multiple settings. It really works like a song. So I really encourage those of you who have a MySeq to try it out. Now, moving on ahead, the second story that I'm going to tell you is our experience working with the state government. Now, we work with a number of state governments in India at a very high resolution. That means a ward level, district level resolutions. The reason why we chose to work with Kerala is primarily because Kerala, like I said, the first case came into Kerala from abroad. Second, Kerala had a very aggressive contact tracing program already very much in place right from their experiences of working with Nipah and the previous versions of SARS. So the healthcare workers were very much prepared to tackle this epidemic. And as shown by the various news articles and from WHO and other renowned places. So and the healthcare system was very open to wanting to embrace technology, and that was one of the key reasons I think we wanted to work with them. So in August-September 2020, okay, around the time when the epidemic was really raging around the country, the first wave, we partnered with this government medical college at Kozhikode in Kerala to take about 250 plus samples and look at what is the distribution of the virus. And to our surprise, it turned out that they're all the A2A clade only. So Kerala became the only state in our country to have a monophyletic distribution of a clade. And this came as a surprise. Remember, I told you Kerala received the first case in India from abroad. There's also a state that gets a lot of international travelers both from Middle East as well as Southeast Asia. So we'd expect a lot of variety of viruses, okay, that international travelers would have brought in. And here, well into the epidemic in August, September, we are only looking at a single clade of virus. What does that tell you? Okay, that really is a very, very important public health message here. I'll come back to it in a minute. Okay. Now, we also went back and said, if the virus did not come from its international introductions, where is it coming from into the state? And by doing the phylogenetic analysis and doing the timeline analysis, we could figure out 3 distinct clusters. Okay, the first cluster was an introduction that happened most likely from Maharashtra between May 11th and 22nd July of last year. Cluster 2 was from Odisha introduction, hopefully somewhere between February and May. And the third cluster happened to come out of Karnataka, or had the common ancestors in Karnataka, which have also happened to be sometime in March. So clearly, you had interstate introductions. That means introductions happening from neighboring states. Okay, and there was proof for it at hand. So therefore, the government could also go back and answer a set of very nice questions by doing contact tracing. Like I said, Kerala has a very good program of contact tracing. They could connect apparently non-connected outbreaks by doing genomics. Okay, and prove that these are all part of the same cluster. They have all been exposed at a single time point, either in a community function such as a marriage, or in a hospital settings. They have been introduced to the virus in a common settings. They could really use genomics to prove that. But the most important was the finding that it was not the international introductions that were causing it. It was the interstate introduction that was causing it. Because remember, Kerala government was taking a lot of bad press, rather, because they were very stringent with their international quarantine. Whereas here they had data now to go back and show that, see, the quarantines really work. We don't have international introductions. Unfortunately, the same level of scrutiny could not be put to the interstate borders, leading to a lot of samples flowing in and causing now the spread within the state. And last year we saw the D614 variant, which is a variant that is known to have high infectivity. So the state had to adopt aggressive measures to curb the virus. Okay, so that's how you convert something like a science as sequencing into pandemic policy decisions. You don't take decisions just based on hearsay or because of a gut feeling. You take decisions based on really hard evidence. Then people tend to follow it better. That has been the experience. So here is an example coming out of Kerala. So once this sort of happened, what Kerala government did with us was to partner along with the Department of Health and Family Welfare at Kerala, the National Health Mission in Kerala, and the CSIR Institute of Genomics and Integrative Biology. All the 3 institutions partnered and said, let's have a long-term program called GeneSCOV-2, basically looking at genetic epidemiology of SARS-CoV-2 in Kerala. And since it started early this year, so we have had, I'm going to show you data till April. Okay, as of April 27th, we have the program continuing, but the data is only till April that I'm going to present. So we have had 4 surveillance rounds that we have done: January, February, March, and April. Okay, and as you can see in the graph here, the first wave sort of peaked for Kerala somewhere in mid-October, and by April, January, February, things were looking calm. Most people had let their guard down, but not the state of Kerala. They kept up the sequencing, and by April they had over 3,000 whole genomes done, and we could analyze them. We found variants of concern, which was the B117, or mostly the UK variant as it was called before. Now it is called the Alpha variant. We also had 31 samples of variants of concern, or the B351. Then 617 showed up in 55 samples, and so on and so forth. Okay, and this is a very powerful slide required for really planning public health measures. Okay, so there are 3 lineages of virus shown here: the B117 or the alpha strain. You look at it in the first far extreme left, it is just as a small percentage of the whole samples that we picked up. Okay, as you can see, just over 1%. Okay, by February it sort of stabilized at 0.8. By March it became 1.73. By again end of March it was 3.8, and in April it just exploded to 20, close to 30%. Okay, so now if somebody were to require a policy decision, it will be bad to take a policy decision on March because nothing much can be done. Okay, or April. You could always look at January, and that is where the surveillance could have really helped in pandemic policy decisions. So you could go back and see how you can look at the emergence of a variant. And similarly in April, the B1.351 genomes and the B1.617 or the Delta strain was just about beginning to show up. Okay, you could also see the birth of the other variants happening. Okay, these are not there in January, February, March, they just showed up in April. And you could do this exercise district by district and then take policy decisions, which district, how much relaxation or how much lockdown you want to do. Here is the close to 14 districts that you see in Kerala. As you can see, not all districts are same, so you need not take the same level of lockdowns in all the districts. You could now plan it properly. Okay, on how this spread of this distribution of this viral strains are, depending on that you could really now decide what you need to do in that particular district. You could now do this for all VOCs also. Okay, as you can see, every one of those districts has a different proportion of VOC, and again this helps in the pandemic policy decisions. Not only that, you could also look at immune escape variants, because we also hypothesize that as people get vaccinated and different pressures are put on this virus, the virus will try to evade the immune system and evolve. So you could also look at district by district, okay, which what sort of immune escape variants are showing up, and if a immune escape variant showed up in a higher percentage, you could have a very localized lockdown of a set of houses or a set of streets or a set of a part of a town or a small community can be put under very stringent lockdown versus rest of the city need not be. So you could take a lot of such informative decisions. But from a 30,000 feet high, okay, this is how the transmission map of Kerala looks like. We practically know every major city, what is the proportion of the virus, which city contributes to which city, which way the data flows. So when the lockdowns are done, they're done with a scientific purpose and not just blindly locking down a complete state. And this is a browsable map by data, by date. So people can pick a date and see how does the genome transmissions change over a full state over a time scale of almost now 6-7 months. Okay, so that is very important for policy deriving policies. This is another way of looking at the same state in terms of a phylogenetic map. As you can see, as we sequence all the 14 districts, you have different proportions of the variants, and you take different measures to really either shut the district or have different levels of stringency of quarantine or lockdowns. Okay, but this is probably the most important slide. Okay, how did this convert into a decision for the second wave? Okay, here is a timeline from April. I told you April we started noticing the what is now we call the Delta strain. Okay, and almost till May 9th is the graph here. Okay, April 25th, the first report to the principal health secretary of health at Kerala government, we told them that there was a B117 strain and there was a B617 associated with high transmissibility that was noticed in the state of Kerala. Okay, moment you provide such a evidence-based document to a public health person, on it 1 day later an all-party meeting is convened to decide on restrictions. A slew of restrictions are imposed to avoid crowding, double masking and self lockdowns are proposed. And I think this is probably the first time where a chief minister of a state went on a state television to say that why double masking is important and why people should do it. Now it has become a common, not at the beginning of the second wave. Okay, and by May 8th, when the elections results were declared, a statewide lockdown was imposed. So now this way of communication of results, people are ready to accept it in a more willing manner, because now you are not saying that you're locking down just because you think somebody thinks that in the hierarchy thinks that it's important to lock down. Okay, you provide evidence to your stakeholders before you take a decision. Okay, so that's very important to engage the public in such large public health measures, and it was very heartening to see Kerala actually do it with a very scientific way and not in an ad hoc way. And you might ask, what did this finally happen? Because Kerala also went through a second wave, but remember, as a nation, Kerala has the lowest percentage death in the second wave. That's a very important statement to make. They have seen the lowest number of deaths in terms of number of deaths that they saw compared to rest of India. And one of the reasons is that they went into a very early lockdown. Okay, they had the infections, okay, but they could manage their healthcare crisis in a much better way compared to many of our other states that we come from. Okay, so that's how you manage an epidemic with science. So the last slide that I would like to stop before I take the questions is to say, while rest of India stumbled, definitely we did stumble. Okay, so this New York Times article really nicely put it. As India stumbles, one state charts its own COVID course. Okay, is because of the kind of science that they embraced, the kind of science that they used to drive policy decisions. And Vinod, who's a colleague here at IGIB, with whom I really closely work in many of these programs, rightly said, it is probably the only state that did not give up on science at any time point during the last 1.5 years. They kept on the science, and today, due to which they are seeing a large number of less deaths compared to rest of India. I'll stop there and acknowledge a large number of people who really contributed to getting this whole thing going. I don't think my team here at IGIB has taken a day's rest since last 1.5 years, led by a very good leader, Rahul Boyer and Abhinav Jain, Paras, Mohit, Disha, Bani, Imran, and Gyan. I can just keep on going. These people have been fantastic. They just were completely put aside their personal time and decided to devote themselves to solving the problem. Fantastic collaborations from across India, from the government of Kerala to a large number of other medical institutions. But last but not the least, okay, a large number of volunteers who came forward to help us, and Council for Scientific and Industrial Research India, who realized early on in the pandemic that India would need a large scale, high throughput genome sequencing and epidemiology platform. And that visionary thought process actually led us down this road. So I'm very thankful to CSIR for this. I'll stop there and take questions. Back to you, Debjani.
Thanks so much, Dr. Sridhar. I think your work kind of conclusively shows how science can actually move beyond academics and be put into a place, for real-time management of a disease. I think it's beautifully captured, and thank you so much for that lucid talk. I have a few questions on my chat, and there are a few questions on the Zoom chat, so I'll probably maybe start with a question of mine. You talked about scale, and you said that it's important that we actually scale up these sequencing initiatives to make sure that we're capturing more information. So with that in mind, do you think so right now, this entire COVID sequencing exercise is probably only limited to a few institutes? Do you think we need to open up this space to maybe private players or diagnostic labs? Because somewhere it's probably imperative to get the scale, and because you also showed that this can happen on benchtop sequencers, that would probably make it easier.
Yeah, so thanks, Debjani, for that bringing up that point. So one of the reasons why only I think government labs have been spearheading this is primarily because it was platform limiting. Okay, these technologies are developed for looking at country level genomes. There is a NovaSeq. Like I said, there are only about a handful of NovaSeq in our country. But the moment you convert that into a benchtop sequencer like the MySeq or the MiniSeq, now it becomes democratized. Okay, now it opens up the avenues for several players, to not only private players, I would say several smaller labs to participate, which have these platforms. So that was one of the motivation we wanted to put this protocol out. So the complete protocol is out there. People who want hand holding, welcome to talk to us. We would be happy to do that. Especially medical colleges around the country. I know many medical colleges have MySeq instruments. They should all be gearing to do it. You can still do 48 genomes every 24 hours. So that's not any small scale from zero currently doing. Same goes for many private players. Now, yes, the current restrictions from the government don't allow private players to participate, but I think it's a very temporary passing phase. Because remember, we went through a similar situation during the RT-PCR times also. Suddenly it all changed. So as the push comes to shove, I think it will change. So it's good. I would recommend the private friends to gear up and be ready, because genome sequencing is here to stay. And I'll not be surprised if your patients come and say that I would like to know my genome sequencing, or the clinicians to say that I would like to know my genome sequencing, but based on that, I want to aggressively treat it or leave it as it is, take a home treatment. So these are all going to be reality. It's not too far off. So be prepared.
Sure. There's a very interesting question. So it says that genome sequencing is great for public health, for epidemiology, but would it actually be used for, clinical evaluation of individual cases?
I think that's where we are heading to.
Yes.
I think that's exactly where we are heading to. Okay. Remember, in last year we only had a variant, the primary one that came out of Wuhan or wherever it came out of. Okay, and suddenly this year we have about a dozen variants that we're looking at, what we call as now officially called as alpha, beta, gamma, so on and so forth. Okay, and we have now newer immune escape variants coming up. Okay, so I think as we go forward, people would really want to know what variants a person has, so that appropriate treatment can be given. And then I also look forward to seeing variation specific drug regimes being prescribed. So these are all going to happen. So this is just the beginning. COVID is not going anywhere, nor are we going anywhere. So we need to figure out solutions to solve them.
I think Gautam also has the same question. Basically, he's saying that do you actually see COVID sequencing becoming a diagnostic test to influence treatments in the near future? And you said
yes, it will.
Yeah. So there's also another question which says that can targeted sequencing be used in place of whole genome sequencing for smaller labs to make it a little cost effective? And would it be able to capture all the variants which one might be interested to know? So
the second part of the question actually has the answer. Okay. Yes, targeted sequencing can be used, but will you be able to capture all the variants? Okay, because these are not single point mutations that lead to a variant. It's sort of a group of the variants that come into a constellation, which then make it into, for example, the alpha strain, the beta strain, or the gamma strain. They're all a set of sometimes as less as 3-4 variants to as high as 20-30 variants that come together to make it. So and also remember, by doing targeted sequencing, what will end up happening is that you're always going to be chasing the tail, because the virus mutates every 7 days. Okay, and what we saw last year, we are not seeing this year. Okay, and I can bet you this time gap between is going to only reduce. So within 6 months, we'll probably have newer variants, and all the ones that you're talking about now, alpha, beta, delta, will all become history very soon. So when you want to devise a policy, you want to look out into the future, and we have it not always go back and tweak your assay. So I think in that manner, whole genome sequencing is here to stay.
There's another question that says that would it be worth doing COVID-19 variant real-time PCR? because
Pretty
there are
much
very
an
few.
answer, the similar answer to gave before. Yes, one could do it. Okay, but again, these variations change so rapidly. Like you said, like I showed with Kerala. Okay, let's say that almost can be replicated to many parts of India. Okay, in 3 months you could go from having that no 0% of a variant to 100 to almost 70% to back to 0%. Today it's in January it was B117 all over the place. Now today it is 617.2 all over the place, which is the alpha versus the delta strain. Okay, I'm pretty sure 3 months later is going to be a different strain. Okay, so
there's
and
no,
the and the life cycle
design
to
it.
develop this RT-PCR or any assay, take it through an accreditation phase, validate it, bring it back into market, produce it, okay,
By that time,
far exceeds the time this virus decides to evolve. So therefore it's going to be practically a very difficult to implement.
So then another question which leads up to that is that based on the sequencing done so far, can we have some modeling algorithms to point out to potential future mutations which point out to the strain evolution? Are we in a position to predict?
Well, that's the billion-dollar question that everybody is asking. Okay, one of the things that we hope to do when we have enough sequencing, no, I don't think it is only sequencing. Okay, sequencing is one cog in the wheel. Okay, it is also understanding the biology of the virus, also understanding how does the virus think, what is it going to do next. Sequencing is just giving you a template to figure out what's going to happen next, but how it's going to behave is in a host is still not understood. So if we can understand that, then I think we'll be able to answer the question that what is going to happen next. Okay, which we do in some diseases for today. For COVID, it's still early days. I think we will get there at some time point, but not in any time soon.
So there's another question which says, have you seen multiple variants present in the same sample, and how do you detect those? Like, do you actually sequence after a certain gap of time, or have you actually come across, maybe a few different clades or a couple of different clades in the same individual?
Yes, we have seen that. Yes, we have seen a number of cases. We also published about it. So usually the first round when somebody gets infected, you find a virus and you document the variations. Okay, and then normally after a period of, let's say, 2 months or something, the person comes back with COVID. Most likely it's a reinfection. Okay, when you sequence it back, you find a new constellation of variants which are slightly overlapping to the previous one, but also has newer entities that you did not see first time. Okay, that could be one scenario where that can happen. Second is breakthrough infections. You took a vaccine and then you had the infection, and previously you might had some other variant that would have caused the COVID in the first place. So there is very good chance, yes, we have seen those same individuals having multiple variants. There's a recent publication also, but there was a very one-off case where they saw something called as long COVID, where one person has COVID for very long time. Okay, then the virus gets to mutate within that person only. So you tend to see multiple versions of it. That could also be possible.
Okay. There's a question that says, out of 1,504 RNA samples processed, only 469 alone were sequenced, were whole genome sequenced, despite having 230 or 95.6%. So I think what they're trying to ask is, why did only 469
yes,
strains or samples give full sequence?
Remember that one particular proof of concept experiment was very important. So therefore it was the bar was kept really very high. For that 469 would have would be the gold data set that we wanted to use for next foreseeable future to compare against. Okay, by today's standard, that number would be close to 600.
Plus, I think when you say 1,500 samples, it was in duplicates.
Yeah, it was it was 752 samples. 469 out of 752 samples. Okay, and that too at a very high stringency. But by normal today's standard, the numbers could be very high. It's not 469; it could be closer to 600.
Okay.
And also let me qualify that last thing. Remember, we had purposefully spiked in inconclusives, negatives,
yes.
also and also pan-Saraboco samples into that data set, which constituted almost about another 200 samples. So technically, it is not 752 also.
Yes.
It is closer to about 500. That's
Correct.
the real COVID samples out
By
there.
that standard, then it's a very good
Yes.
proportion of, yeah.
Yes.
Dr. Uma from AIMS, so what she's trying to say, in what percentage of reinfections do you actually find that the strain is different from the first infection?
So what?
Based
So
on whatever.
I can get you a number for that, but I think in majority of the reinfections, the strain was different.
Okay.
Okay, but I can get you an actual number. I think there are only few cases in which the same infection was shown, but majority, I would say, the strain was a different strain from the first infection.
Sure. There's a question that says, apart from genomic surveillance of the pathogen, is there any study which IGIB is doing to monitor host-pathogen interaction, like from the point of view of host? And basically, in what groups of patients would you actually classify, more severe form of disease versus a less severe? I mean, are you all planning to do some host-based studies as well?
So IGIB has a wide variety of studies that are currently ongoing. The host pathogen interaction is one area that we are keenly looking into. My colleagues at IGIB are doing it. I don't do it. Yes, but again, the challenge is that the virus changes so rapidly that before you establish a cohort, you are able to analyze those samples. The virus has turned itself into a different beast. So that is becoming a problem into keeping pace with the biology that we want to do with this. But at some time point, we will catch up. So I leave this question for answering at a future time point when we have enough data.
Yeah. And also, and probably an next question is that in a lot of mortalities, we've seen that there were cases of mixed infections. So are there any studies where, basically the entire pathogen ecosystem is being studied, and, in what, are those studies in place, or are there any plans to do those kind of studies?
I'll go to my own experience about 7-8 years ago. Okay. So what Vinod, my colleague, Dr. Vinod Skaria, and myself had come up is that we kind of hypothesized that all infections are going to reside in sort of in a mixed environment of symbionts of infectious agents and maybe commensals, opportunistic pathogens, so and so forth. Okay, that's the reality. It's never going to. But however, in an active infection, the infection should be a log fold higher than rest of the background. Okay, so we called this the holo genome sequencing, and we did try this out in a real life situation in the Gorakhpur epidemics that had struck in 2009-2010. Okay, and we were able to identify the causative organism over all the comments. We had a total 3,000 background in comments, I would say symbionts or commensals that were there, and then we had this one pathogen virus that was causing it. That was my first brush with mixed pathogen sequencing. Yes, it can be done. Algorithms exist. Sequencing methods are very well adapted for it. Doable.
Sure. Will India set up, just like UK, a pandemic radar? Or, even in US, for instance, there is this organization called SPEARS, which basically gets a lot of private, government agencies, etc. Should this be now the starting point for the government to utilize genomics for quick tracking and local containment? And do you think there is now a, enlightenment in the government regarding this?
I think it is time that we should have such policies in place where we could be doing constant surveillance, because earlier, though viruses such as Nipah and previous epidemics have come and gone, I think we were just lucky enough that they did not explode out of control, or due to watchful actions by very, very committed individuals like my friends down in Kerala, who managed to at least control the Nipah and the previous viruses. Had it not been for them, we would have seen this earlier. So I think it's important to do that as a nation, and I hope India does it too.
Sure. Okay, let me just kind of see. Vaccine. How many would be escaping? Okay, so I think, yeah, I know you have a hard stop very soon. So I think we just probably, I think we'll call it a day now. And there are some questions which probably, still need answers. We'll get back to you over email. So I really thank all the people for joining us here in the session. A huge thanks to you, Dr. Sridhar, for sharing your experiences with us. I think there have been a lot of people who joined the session just to gain knowledge and probably also to find out how they can, do this same thing in their labs. So I think in that respect, they've gained a lot through this talk. And thanks a ton for your wonderful piece.
Sure. Thank you. And thank you and Team Premas for hosting me, inviting me for the inaugural session. It is always a pleasure to talk to like-minded genomic scientists and medical personnels around the country. Those who are interested can contact us at IGIB. Our emails are on our websites. Feel free to contact us, and we would be happy to handhold you in case it's required to set up a genomics unit at your place. We'll be happy to do that. But thank you, Debjani. Thank you to Team Premas and everybody for hosting me today. Thank you.
Thank you. Good evening and have a happy weekend, all of you.
Yep.
Yeah. Thank you, everyone. And those who are asking for the feedback link, so we'll be sharing the session recording and the feedback link will be in the same email. You can also drop in more of your questions in reply to that email. We'll answer rest of your questions on the email. Thank you, everyone, once again, and have a good day. Bye-bye.
Bye-bye.